to everyone joining us from all over the world. I'm so thrilled to have you guys here with us today for a little review of our pediatric GI disorders. My name is Morgan with Archer Review. I'm a pediatric nurse practitioner. I love the kiddos with all my heart. I've never done nursing in the adult setting because kids are just way too much fun, if you ask me. So today we are hopping into the most common GI disorders you see in peds. GI is what I kind of consider one of the big three systems that we really have to nail for our NCLEX in peds, because there is just a lot that can go on, and it can be a little challenging to remember. So my big three objectives for you guys today is that you can identify what these disorders are. As I said, there are a lot of them, so we're going to try to break it down, make it a little easier to remember. I then want you to be able to assess them. I want you to actually be able to look at a child, look at what other things are going on, what's normal and abnormal with these different conditions, and then understand what we want to do about it. And as you're going to see, we're really going to break that down into pre-op and post-op. So at the bedside, what do I do before they go and have surgery? What do I do after? Okay, that is what we're going to be jumping into today. So let's make sure everything is working. Make sure we get our screens. I think we are in good shape. Okay. Don't have anything to disclose for this webinar, no financial relationships at all, and we're going to kick it off with a little pre-test. I essentially want to know kind of where you guys stand, okay? Because I know some of you are already out there practicing, some of you are just starting nursing school, and that can look a little bit different. So what we're going to do, go ahead and either scan this QR code if you're joining on your computer. That's like probably the easiest way to do it. You can also just type this little link in, and it's going to give you just 5 simple questions. You're not going to get the answers though, okay? I don't want you asking me what the answers are yet. I'm going to talk about the answers throughout the next hour, and then at the very end, we're going to do a little post-test, and we are going to make sure that it all actually makes sense, okay? And you're going to get a copy of these questions and your answers to them to your email. So when you fill it out, you're going to have all of that to refer back to later. It should happen automatically. Okay, so I'm going to give you guys a few minutes to get that little pre-test going. Hopefully it's already pretty straightforward. Let me know if any of you guys are having any trouble. Looks like we're doing pretty good. It should be pretty quick. All right. Nice work, nice work. So as you guys are finishing up that pre-test, let me give you a little bit of the lay of the land, how we're going to walk through this lecture. We're only going to take an hour here today. We're going to knock it out really quick. And we're going to go in the only order that I can think is logical for the GI tract, basically starting at the top and working our way down to the bottom. We'll kind of trace the path that maybe a sandwich would go through your GI tract. And we're really just going to focus in on those high yield congenital disorders. Now, will I be touching on every single congenital disorder of the GI tract? No. That would be a really long webinar, and it would be above and beyond what you guys really need to know as new grads. So our focus today is to try and follow that logical order, make it really simple so that you guys can understand the most important concepts. Okay, give me a thumbs up, a like, a comment if you guys are ready to jump into the content. Do you need a couple more minutes on the pre-test? Or are we ready to go? Alicia's ready to go. Love to see that. Angelica, Amber, all my A's ready to go. Telly. Okay, that's perfect. You guys are ready? Let's start at the top, like I promised, with kind of the mouth, the lips, and a disorder I'm sure you guys have heard of before. It's called cleft lip. Cleft is basically just a little slit, a little gap or opening. And it can be on one side, so just unilateral, both sides, bilateral, and it can happen by itself or with something else called a cleft palate. Again, cleft, just a slip or a gap, and the palate's that hard upper roof of the mouth, okay? So that's kind of what the palate looks like. If you're looking up in the roof of the baby's mouth, there will be an opening. Again, you can see it with a lip or without a lip. And when you go to assess this infant, of course, the most obvious part of your assessment is that you're just seeing this defect. But I need you to dig a little deeper. You need to then look at their airway, their respiratory status, and their feeding, because their mouth, their palate, very important to all of those essential body functions. So really, feeding, hydration, nutrition, and weight gain, those are going to be big parts of your assessment when you've got a kiddo with a cleft lip or palate. Obviously, our management here needs to be surgical. There's no magic medication we can give them that just closes that up. So our care is really divided into what we can do before surgery and after. That surgery happens always in the order of cleft lip first and then cleft palate. The lip happens first at like 3 to 6 months of age because we really want to go ahead and correct that before speech starts being developed. It's a lot harder to learn how to say all your words when you've got this big gap in your lips. So we want to fix that first, and then the palate at 6 to 24 months of age. We never do them together. It's just not how it works. Now, before they have that surgery, we're going to be really focusing on what we just talked about, monitoring their airway, not letting them aspirate, making sure they can feed well. How do we feed those babies? All right. Specialized bottle. Basically, when we've got this big gap going in here, it's a lot harder to latch on to either breast or bottle. Yeah, so that's why we need to help them out with this specialized nipple, feed them upright, small frequent feedings, and burp them a lot. We basically just want to prevent them from getting too much air in their bellies. And when they've got a big, hole going on right here, a lot of air can come in. They might take longer than other kiddos to eat. They are at high risk for aspiration. So that's really what you're going to be focusing on. Now, post-op, we're still going to make sure we're feeding them good. We're still going to upright for feeding. We still want to prevent aspiration. But we've got one more additional nursing consideration that we didn't have pre-op, and that is protecting their sutures. This is a very delicate plastic surgery, and 3, 6, 12-month-olds, they like to grab at everything possible. So if they are grabbing at their face, their suture lines, that's going to rip things open, and really, that's not going to be so good. Which is why, to protect those suture lines, we oftentimes use something called an elbow restraint. This is basically like a little board that gets put on their elbow and wrapped up, just so they can't bend their elbows, okay? So it's not a crazy invasive restraint like, tying them to the bed. It just stops them from bending their elbows and getting things into their mouth. So you don't need an order for these. These are very common in kids, and it's really helpful after a surgery like this so we can protect those sutures. Now, other ways we protect the sutures are just not letting anything hard or sharp into their mouth. So straws, pacifiers, oral suction, keep it away. We just want to keep those sutures safe. In line with keeping the sutures safe, but then also preventing aspiration, how should we position these kids? There's a lot of questions about this. A cleft lip should just be positioned where they're comfortable. They can be on their back, on their side, sitting up. We always sit up for feeds, but we don't want them positioned prone, because if they're laying on their face and they've got sutures right here, that's going to be a really big problem. They're going to totally mess those sutures up. For a cleft palate, we can put them prone. And that is a wonderful way to prevent aspiration by allowing them to kind of drain some secretions from their mouth while they're on their belly. I know that's really confusing, so I always remember P for palate, P for prone. We can prone a cleft palate, but not a lip. Okay. Let's move it on down from the mouth, that cleft palate, that cleft lip, down to the trachea and the esophagus. You guys know normal anatomy. Let's look at the normal anatomy first. We've got mouth to esophagus to belly. We swallow and our food goes down. Perfect. And then next to that is our trachea, where we breathe in and that air goes to our lungs. Awesome, awesome. So we don't want those getting mixed up. We want food in the belly, air in the lungs. In tracheoesophageal fistula, we have a joining of the trachea and the esophagus. And then in esophageal atresia, we have a not developed or a part of the esophagus that doesn't get formed. So let's look at what that anatomy looks like. Not so good, not so good. So let's get our pointer out here just so I can really call out for you guys where this is. Right here, that's the esophageal atresia. That's where that esophagus should go all the way down to the belly, and it just doesn't. It's got kind of a dead end pouch going on. And then right here, we've got the trachea, and it joins up to that esophagus. So that's that fistula, that joining of trachea and esophagus. And this is obviously going to create some problems for us, right? Because now we don't really have good pathways for air and food. What's going to happen the first time this baby goes to eat is they're going to be choking, coughing, and they're likely going to start to turn blue as their milk goes into their lungs instead of their belly. This is kind of what it looks like on a little X-ray study where you can see that dead end pouch from the esophagus. Food just goes in and comes right back out. Obviously, this needs a surgery. Most of these things are going to require surgery. And the biggest point that I can tell you guys is that before they get this surgery, we have to keep them NPO. Like, not just, no food here, there. Like, they have to totally not have anything going in their mouth because they can even just choke on their secretions, their saliva. Sometimes we'll put a little NG tube just right into their esophagus and put it to suction so that we get all those secretions out of their mouth and they don't go down the wrong way. All right, so that's going to be the biggest thing. The surgery will repair all that anatomy, and then post-operatively we'll work on nutrition. Because think about it, how are we feeding this baby before surgery? Could I put an NG tube? Like, go back and look at the anatomy. Can I put a tube down their nose and into their belly? Can I let them eat by mouth? No, I cannot do any of that. Remember, if they have food go down, it's choking, coughing, and cyanosis. So my only option for nutrition pre-operatively is either to go to surgery and have a G tube put right in their belly or to use TPN. And those are both, longer term solutions. So they haven't really gotten great nutrition before surgery, which is why after surgery, that is the priority. Okay. So we went from mouth to our esophagus all the way down. Let's now look at the intestines. Food has actually gone all the way through the belly. Now we're in the intestines. What we've got here is something called an omphalocele. This is an anomaly where the abdominal organs, like those intestines, like the spleen, the pancreas, the liver, they actually push through the belly button and develop outside the baby's body. They develop for a long time outside the baby's body, about 30 weeks, because this deformity occurs around weeks 9 to 10 of gestation. And then we go in for an ultrasound and we can see, those those organs are growing outside the baby. That's not where they're supposed to grow. And when they're born, that's really what we see. We see from small all the way to a giant defect. These can be different sizes for sure. And some infants only have the omphalocele. Some, they've got other defects as well, like a cardiac defect, their lung size can be affected. But what I'm really worried about are these three big complications. The first one, hypothermia. They are losing body heat. Their organs are outside, they're evaporating heat, and babies aren't great at maintaining their own body heat as is. Usually I would swaddle them up, put on a hat and socks, put them skin to skin with mom, and they'd be perfect. Do you think, looking at this anatomy, I can do a nice tight swaddle on this baby, put them skin to skin? No, you guys are totally right. That's not going to be feasible because we're going to be pushing on these organs. It's going to cause all sorts of distress. So that's not going to work. We're going to have to use something called a radiant warmer. That's in this picture right here, all the way on the left. We used to call them giraffe beds because they've got this like long arm and kind of like head looking thing. So it kind of looks like a giraffe, but it's basically a heat lamp. It's going to put off heat and warm that baby up, even if they're naked. So we don't have to swaddle them up. We got to just give them some heat. Now, the second complication I'm worried about goes hand in hand. They're losing heat to their environment, and they're also losing fluid. So they can become dehydrated rather quickly. And that's why we need to put them on some IV fluids. What fluids should we put them on? Well, think big picture. This baby's going to need nutrition somehow, right? And once again, with a belly on the outside of this baby, are we just going to let them eat from a bottle? Can we even put a G-tube in? We don't have a lot of options going on here. We've got to use an IV to deliver their nutrition. We've got to do that total parenteral nutrition. And that is going to provide hydration and fluids, and nutrition. So it's nutrition and hydration, preventing that dehydration. Now, the third and final complication that we have here is that because these organs are outside baby's body, we can get a lot of germs going in there, causing them to get infections. Sepsis is a really big risk in these infants. So oftentimes they're on some antibiotics to prevent that. Now, big picture, I'm working to keep them warm and get them hydrated, but is that going to fix our problem? No. Again, obviously, we need surgery. We need to do a surgery to get these organs back inside of the baby's body. And I wish it was just like as simple as that. It's like the baby's born. Oh my gosh, let's go to the OR. But unfortunately, this is actually very complicated and it takes a long time. Because remember, these organs, they were on the outside of the baby's body for like 30 weeks. So the body's not used to them being inside. It's grown and accommodated them being on the outside, which means we have to slowly make room for these organs. So what the surgery team does is they use something called a silo. I'm not gonna lie, this is kind of like fancy plastic wrap. It's really nothing that impressive. They kind of wrap up the outside of those organs. They keep them over that baby's abdomen. So it's like putting a little pressure there and slowly but surely, day by day, lower them back into the baby's abdomen. They're kind of like elbowing their way in, like make some room for me. But we don't want to traumatize the organs. So we're doing it slowly. Once the organs get far enough in, that's when they can go to the OR, close them up. They'll have a pretty good scar on their belly, like you see there. Be better, good to go. So our care, we really talked about that pre-op care. You guys are making sure to keep the baby warm, hydrated with TPN to get their nutrition. One thing I didn't mention is that those organs really need to be kept moist. We don't want them to dry out. So a sterile moist gauze is typically placed over the omphalocele. Okay, we did all the pre-op stuff. We put the silo, got him to the OR. So what now? Now we really need to work on eating. Before they were just doing that TPN, and we don't really want to go home on TPN. But they have never had anything in their belly before. And it has been weeks, if not months, getting ready for this surgery. This is a super long hospital stay. Most of babies with a big omphalocele, they're in the NICU for at least 4 to 6 months and sometimes longer. So how do we wake that belly up? We do something called trophic feeds. To be honest, I don't know why they call it trophic feeds, because it's just very little itty bitty gradual feeds. It starts off with like 2 mLs. We gradually drop it into their belly, say, wake up, wake up. And the next day, maybe we do 3 mLs, then 4 mLs. Slow and steady. If you go too fast with these babies, their intestines kind of shut down and it is not good. So eventually they'll be tolerating more feeds, right? We can give them a bottle and that's when we'll transition them to home. But it does take a long, long time. Okay, now I want to know, have you guys heard of an omphalocele? Have you heard of a gastroschisis before this webinar? I'm not going to make you listen to me talk all the live long day about a gastroschisis because it's very, very similar. But I need you to know that term. I don't want you to be thrown off if you see that. A gastroschisis is another defect in the abdominal wall where organs come out, but this time it's only the intestines. Remember the omphalocele, we had all sorts of things coming out there. You could have the pancreas, the spleen, the stomach, the intestines, and they were inside of that peritoneal sac. That's what our little drawing shows right here. That's supposed to be a peritoneal sac. So they're kind of at least enclosed a little bit, but a bunch of organs are out there. In the gastroschisis, it is just the intestines, but they are not inside that peritoneal sac. They are just wide open, totally exposed to the elements. So those are just the anatomical differences of a gastroschisis versus an omphalocele. The treatment we just talked about, totally the same. Pre-op, prevent dehydration, thermoregulation, get that silo, get the organs back in. Post-op, focus on nutrition. So you guys don't need to listen to me go over that again. Instead, I want to check your knowledge quickly with a little question. And we're going to use something called Slido so that you guys can let me know really easily what you think. If you're on your computer, you can join with this little QR code. If you're joining from your phone, you can just pop over to slido.com and put this little code. And then as soon as you're in there, I'm going to go ahead and pop the question up. That way you guys can do a little practice, do a little knowledge check, make sure you're understanding these things before we keep moving. So here we go. We've got a scenario. A parent is swaddling their infant with an omphalocele, and I want you to tell me what to say. Hey, here we go, here we go. Very good. You guys, so smart. Absolutely. We want to offer to help. We want to let them know, hey, we can't just super tightly swaddle them up and push on their intestines. We want to let them know why that would be dangerous, but we'll provide that education in a nice, reassuring way. It's not a good idea to say, stop, you're going to kill your baby. But it's also not okay to just let them do it without helping them, right? So nice job. Okay, you guys have got it. Let's go forward to our next defect here, where we are going to move into the pyloric sphincter. And this is the little muscle that connects the stomach to the intestines. And the pyloric sphincter is kind of like the gateway that keeps food in the stomach when we want it in the stomach. And then it opens up and lets that digested stuff go into the intestines when it's the right time. So if that sphincter, if that gate gets swollen, big, hypertrophied, it's going to kind of block food from being able to move from the stomach to the intestines. So it's just going to stay in the stomach and build up until there's too much pressure and we have projectile non-bilious vomiting. That's kind of the key word for pyloric stenosis that I want you guys honing in on. If baby eats and then right after they eat, that milk comes right back up and it is so forceful, it is like hitting the wall, that should be a dead giveaway for pyloric stenosis because that food, it's getting into the baby fine, it just can't go past the stomach, so it comes right back up. That obviously makes them dehydrated, can lead to malnutrition. And on assessment, when you hear all these things, I want you to then go and palpate, push on that baby's belly. Feel around, and if you feel a big olive-shaped mass, that's that palpable pylorus. It's there blocking that flow of food, and we have pyloric stenosis. What do we do about that? Well, got to do surgery. I told you, the pediatric GI surgeons there, they picked a good profession. There's a lot of these that require surgery. It's called a pylorotomy, and they're just going to take out that stenosed pyloric sphincter. The big thing for us, since we're nurses at the bedside, is that we're focused on this baby's hydration and nutrition. Because if they're throwing everything up, they're going to be dehydrated. So I might need to get them some IV fluids. And then after surgery, we really want to beef up their nutrition so they can grow and develop. So tell me, we'll stay on the Slido train. If you're palpating that baby's abdomen, what's the mass going to feel like? Olive shape? Okay, good. That's what I want you to remember, you guys. Very nice. An olive-shaped mass. I'll go ahead and warn you, I don't know why whoever named all these signs and symptoms, they must have had food on the brain because they're always comparing the mass or the poop to some random type of food. So I apologize in advance because it sounds very gross to me. But yes, this is what you're going to see on your boards. It's going to say olive-shaped mass. So I want you to automatically know, boom, we are talking pyloric stenosis. Okay, let's move a little further down, back to those intestines, right where kind of the small and large intestine combine, or where they meet. And usually they should be like this, where the small intestine just flows right into the large intestine. But one thing can happen where the small intestine kind of pushes its way into that big intestine, like this, and they kind of double up or telescope on top of each other. That's called intussusception. And this is the first thing we are talking about that's not a congenital anomaly. Intussusception happens later. About 6 months to 2 years is when I have seen it most commonly. But it can happen at any age. It can happen in the elderly, just not very common outside of kids. But they're not born with it, is what I want you to realize. Everything else, pyloric stenosis, omphalocele, tracheoesophageal fistula, those are just things they're born with as babies. Intussusception happens later. Okay, small intestine goes inside of the big intestine. They're stuck together. The key signs and symptoms are that when mom goes to change this diaper, she says, oh my gosh, their poop is like red jelly. It's this bloody, sticky goo. Red currant jelly is the description that they came up with for what this stool looks like. Now, they've also got a mass. This one looks a little different because it's kind of where those intestines are doubled up on each other. Yeah. So this is a sausage-shaped mass. And the location of that will depend on where the intussusception is. If it's at kind of that classic location, it'll be in the right lower quadrant. What else is going to be going on with this kiddo? Well, they're going to be in a lot of pain because their organs are twisting up on each other. It's going to kind of come in cycles. They'll be screaming with their legs drawn up in intense pain, and then it'll pass. And then they'll be screaming. So it's this cyclical, intense abdominal pain. They're nauseous, they're vomiting. This is obviously very painful. So that vomit, now it is a green bilious MSS because that food has made it past the belly into the intestines. So there's bile digested in there that's coming back out. With pyloric stenosis, it never got past the stomach. So it was non-bilious. It was just straight up that formula or that breast milk. Now, what causes intussusception? Great question that we don't have a perfect answer to. There are some viral infections that increase the risk of intussusception, but they don't always cause it. Sometimes it's totally, we don't know why, idiopathic. It kind of is just a random thing that happens a little bit in that toddler age. And it's not super common, but if you work in a pediatric ER, you are definitely going to see this at some point in your career. Now, this is one that sometimes we don't need surgery, okay? We will first try to give them an enema, causing them to have kind of a more forceful bowel movement that pushes those intestines back out. And I always say, unintussuscepts them. That's not a real word, by the way. In my brain, that's just what's happening. It's pulling those intestines back out. Now, this is supposed to be very effective. I have personally never, ever seen it work, and they all end up going to surgery to repair the intussusception. So we're back to pre and post-op. What do we do as the bedside nurse? We monitor that stool. We keep them NPO for surgery, give them fluids and antibiotics. Why antibiotics? Well, we're doing surgery in the guts where there's a lot of poo. I'm just going to say infections after a GI surgery, very common. So you're going to see most of them get antibiotics so that we don't have those infections. Post-op, we're monitoring for those infections. We want to know, is their white blood cell count up? Do they have a fever? We want to really keep a close eye on that and slowly advance their diet. We're not just going to let them have a Big Mac right after surgery. We want to give them a little food, wake their belly up, keep an eye on their stools, and when they've kind of had a normal stool is when we can amp things up a little bit. Okay, so what do you guys remember about the cause of intussusception? Is it congenital? Are they born with it? Like they are with pyloric stenosis or an omphalocele? How do they get intussusception? I love it. Nope. Intussusception is not congenital, all right? Babies aren't born with it. It's something that happens later. And while we do know some viral infections increase the risk of it, we don't have a perfect answer for why intussusception happens. A lot of times, it is super random. Okay, now the last disorder that I have to put on your radar is another congenital one. This is something babies are born with. We've made it all the way down to the very end of the rectum, and now we've got Hirschsprung's disease. The other name for this is something called congenital aganglionic megacolon, which is a bunch of mumbo jumbo, but if you break it down, it really does tell you what's going on. It's congenital, they're born with it. Aganglionic, ganglions are our nerve cells, so without nerve cells. And megacolon, a really big colon. We all know the colon is that ending part of the small intestine, or the large intestine, excuse me. So what's happening here is the baby is born without nerve cells in the ending portion of their colon. What do nerve cells do for us in our colon? Well, they stimulate peristalsis, that movement that pushes food through the GI tract. And if I don't have nerve cells, I can't move food through the GI tract. So it's just going to sit there. And it's going to make the colon get bigger and bigger and bigger until we have a megacolon. A ton of stool built up at the very end of that large intestine. Oh, this sounds so uncomfortable. One of the first things that we will see in these infants is a delayed passage of the meconium. Meconium is that first sticky, tarry stool of the newborn that should really be passed within 24 hours. Sometimes we'll say, oh, okay, up to 48 hours, but if you haven't passed it at that point, we've got a problem. And these babies, they don't have the nerve cells to move that stool through the intestine, so they've got delayed passage of that meconium. Now, eventually, as they get bigger, more and more stool builds up. Their belly gets bigger and bigger, lots of abdominal distension. When they vomit, it's not just bilious, it's a dark green-brown substance because that stool is literally just backing up so far that it's coming out the other end. It has nowhere else to go. If any stool does come out the other end, it's going to be this ribbon-like stool because it's not peristalsis pushing a bowel movement through, it's just gravity kind of pulling some of that out. So ribbon-like stool, that's your key buzzword for Hirschsprung's disease. And what are we going to do about it? Y'all know it's going to be a surgery, right? We got to cut out that part of the colon that doesn't have nerve cells. It's got to go. It's got to go. If it doesn't have nerve cells, it cannot do its job. It cannot move food where it needs to go out of the body. So we're going to get rid of it. And then we are going to reattach that good part of the colon in what's called a pull-through procedure to the rectum because it does have nerve cells and it can move that food for us. So then after surgery, really our focus here is nutrition, okay? It's not that they couldn't eat before. These babies, the anatomy up top is normal, so they can eat, but that food gets blocked up. It can't go anywhere. So then we've got all these other symptoms, and of course, they're not feeling well, they're not eating well. So that's why nutrition after surgery is so important. It's really one of those that you solve for every single disorder we talked about today. And we talked about a lot of disorders, fast and furious. So I really want to summarize it. Before we do a post-test, before we check in on your learning, we want to make sure we hit those high points. I want to see thumbs up that you guys know this stuff. This little chart, it just breaks down what, in my opinion, are the most common signs and symptoms that you're asked about on your exams. First, for pyloric stenosis, you'll see up top, it's what kind of mass are they going to have? That one is that olive-shaped mass. Because remember, it's that pyloric sphincter that's getting big and swollen and it's just protruding. So we're feeling that olive-shaped mass. Secondly, what's their vomit look like? This is when we have the projectile non-bilious emesis. Remember, food goes in the belly, door is closed, it comes right back out. So it's not digested, it's just that formula. And it is projectile, it is hitting the wall. Okay, next up, intussusception. Remember, this is our one that is not congenital, happens a little bit later. Their mass is a sausage-shaped mass because it's where those intestines have kind of doubled up, yeah? When they have emesis, it is a green bilious emesis. The food has made it into the intestines. It's been digested. It's got bile in there, and then it comes back up. And their stool is that classic red currant jelly stool. All right, once again, I don't know whose mind was coming up with these symptoms. We've got olives, sausage, jelly, but those are your signs. Those are your signs and symptoms. Last but not least, over here on the right, your Hirschsprung's disease. This is congenital. They don't necessarily have a protruding mass. You might be able to feel a large stool burden with that megacolon. You might be able to palpate that. But really, their emesis, it's that green-brown, because it's all that stool backing up, 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 since it can't get out the rectum. Any stool that does get out, remember, it's just gravity pulling out that ribbon-like stool, Okay. Hopefully that helped you guys summarize it, because I know it is really, really challenging. Before we do our post-test, before we make sure everybody's good, let me leave this open for some questions, okay? I see one question over here in intussusception: where is the mass palpated? And that is going to be usually in that right lower quadrant where that small intestine meets that large intestine. But let me tell you that intussusception can happen in different places, okay? It's not always in that same spot. So it will somewhat depend on the client, okay? All right, let's see. Are there any diagnostic tests to assess for tracheoesophageal fistula right after birth? I like this question, okay? So remember, we put up that image. Typically, we're going to get an x-ray just to see the anatomy. But I also have another little trick that you guys can use. A lot of times, if we are suspecting tracheoesophageal fistula, the baby is choking, coughing, and turning blue, right after birth, we will insert an NG tube and see how far we can get it. And if after 8 centimeters, 7 centimeters, we hit the end of that esophagus and it just turns around and comes right back out towards you, you have a pretty good indicator that that esophagus is not normally developed. So it's very crudely just, how far can this tube go in? Does that diagnose tracheoesophageal fistula? No, we still have to get that x-ray. We've got to get the imaging. But it can let you know, hey, this is kind of what we're thinking, right? This is kind of where my head is at. Okay, let's see. That's that one. We've got it. Can I renew the video SurePass combo? Yes, absolutely. After we get through our PEDS GI questions, I am more than happy to stay on and make sure you guys can get those more, Archer Review specific questions answered. But you can absolutely renew any of your products: QBank, Video, SurePass, whatever you need. Let's see, a question here on Zoom. Are these items the most common pediatric issues tested on the NCLEX? Yes, absolutely. That is what I am going for today, making sure you get the most high yield content. In gastroschisis, do we also cover with a moist gauze? Yes, very important to do that in gastroschisis, because we really don't want those intestines drying out. Really good question. I liked that. Both gastroschisis and omphalocele, covering with that moist sterile gauze, very important. What age is intussusception most common? So this is the one that, yeah, it can happen anytime, right? But most of the time, it's between about 6 months and 2 years. The oldest I've ever seen it is in a 5-year-old. The toddler to very early school age, most common. All right, so if we have pyloric stenosis, we do that pylorotomy. How does that look after surgery? What's going to happen to their digestion? Really smart. So these surgeons are artists. They're very good at what they do. And while they don't necessarily have that pyloric sphincter, they're either going to use other muscles to kind of replace that, or they're going to kind of cinch that pyloric area between the stomach and intestines, so they will have a relatively normal digestive process. Pyloric stenosis, it's one of those that it's super scary, your baby needs surgery, but it's a fast fix and they usually have a really good prognosis. Do these conditions, are they affected, or are they detected, during pregnancy? Yes, almost all of these we can pick up with a prenatal ultrasound. Some are easier than others. An omphalocele we can see really easily with a prenatal ultrasound. A tracheoesophageal fistula, that's one of the ones that's a little bit harder. So that one might be a surprise after delivery. None of them are 100%. We can always see things unexpectedly, but our prenatal ultrasounds are very, very good nowadays. And yeah, a lot of these things we can find. In Hirschsprungs, is it possible that more than half of a colon doesn't have innervation? I can't tell you specifically the percentage of the colon that has innervation, but for the majority of cases, it is only enough of the colon that we're still able to take that part away, do a pull-through procedure, and they're left with enough of that colon that it still functions normally. So while I don't know the specific numbers to tell you, and that wouldn't be something that would come up on your NCLEX, the majority of the time, it's not so much that it's going to affect their absorption and nutrition for the rest of their lives. We can remove that part that's not working and they can still function a-okay. Will I be able to access this recorded video later? All right, great question. This specific webinar, since it was just a free webinar Wednesday, it's not going to go in your Arch Review student portal. It will live on YouTube and Facebook, so you can totally check it out there. And on your student Arch Review portal, you'll have a much more in-depth pediatric video that includes all of this information taught by me. So you'll be able to access that on demand in your portal. Okay. Hopefully I've answered most of the questions. I know there's a few outstanding. I'm going to make sure I continue to answer them, but as we do so and get closer to wrapping up our hour, I want you guys to go ahead and take your post-test, okay? So either scan this QR code if you're, on your computer and you've got your phone handy, you can do that shebang. If you're just on your phone, maybe you want to type in this link. I can also pop the link in here for all of you guys. And now you are going to be able to see the answers. I want to see what you have learned. I want to see if you have been able to get something out of this. Hopefully you guys will see, oh my gosh, this is looking so much better. I feel so much more confident than I did when I started. So that is in the chat there. I will continue answering questions while you guys take that post-test. And if there's one from post-test that you're like, this makes no sense, can you please help me out here? Then I will happily go over that with you guys. So go ahead, take your little post-test and eval. When you submit it, those answers and the rationales are going to go to your email. So you're going to see all of those correct answers. You're going to see why they're correct and incorrect. And you're also going to see what you learned. You're going to see what you got wrong an hour ago and what you know now. I'm thinking you guys are going to get 100%. You guys have been awesome today. You've asked really good questions. So I think you are all in great shape. All right. So while you guys are doing your post-test, I will make sure to keep asking or answering any questions at all that you have. If you've got them, you can always comment, send them in the chat, the Q&As, and I will make sure to continue reviewing. So when it comes to the renewal question, how do I renew my on-demand combo, my SurePass, my QBank? We try to make it really simple and really affordable so you guys can keep reviewing for as long as you need to. There's basically just a renew now button at the top of your dashboard. So you'll be able to click that. I can't tell you exactly the price because it's going to depend on what you have purchased and how long you want to renew it for. For example, if you've got our SurePass combo for $159 and you want to renew it for another 60 days, you just click on that button, click on 60 days, and it's going to give you your price. You can go ahead and click that, and boom, you automatically get access. Now, if you're testing a year from now, you're super prepared, you're on it, but you don't necessarily want to activate your product right now. You can absolutely still go purchase any of our products, lock in our prices that we have right now, and you can wait to activate it until you want to start studying. You'll get an email to confirm your account, and when you're ready, you'll click on your activate button in your student dashboard, okay? So that's a nice thing about Archer. If you want to go ahead and lock in 2024 prices will go up next year. So if you're, a couple years away, it might be smart to do that. And if you need help choosing the package that's best for you, you can either go to our website and click on the suggestion bot. You can kind of tell it like, this is what I'm looking for. These are the times of days I like to study, and it will give you some suggestions. Or you can email us at nclextutors@archerreview.com. Tell us a little bit about yourself and what you're looking for, and we will gladly help give you advice about the package that will best suit your needs. Because we don't want you to overpay. We don't want you to have to get too much. We really, really want to help you find what is right. If you're traveling, if you're in a different country, you can absolutely still attend the review. I'm happy to say we have students joining us from all over the world, and I absolutely love getting to see where you all are joining from. So please join us from anywhere. How many percentage do you have to do on the Archer Review Q-Bank? All right, this is a good one. So for all of you doing the Archer Review Q-Bank, PN or RN, there are a lot of questions in there. Yeah, it can be a little bit overwhelming when you're getting started. I always tell students, everyone's a little different. One of us may need to do a little more, one of us a little bit less. So there's not a number of questions you have to do. Instead, what I want you to focus on is achieving a high or very high score on 4 readiness assessments, okay? That tells us that we're kind of ranking you compared to your peers where we have that passing threshold, which is just how the NCLEX does it. And that tells us how likely you are to pass the NCLEX. Let me tell you, every student, almost every single student, 99.8% of students who get 4 scores of high or very high in a row, they go on to pass their NCLEX. So that's where I want you to focus. I don't want you to worry about numbers. Percentages are confusing. Focus on that readiness assessment, high, very high. What about the computer adaptive tests? Those are wonderful to do about once a week for testing endurance. That's going to help you be prepared for those 150 questions, get a very similar experience to the real NCLEX, but the score just tells you pass or fail. It doesn't give you as much nitty-gritty info as a good old readiness assessment. So we're using readiness assessments to predict our chance of passing. We're using CAT exams to get ready for that testing endurance. The NCLEX is very similar to the Archer Review readiness assessments. I will tell you this all the live long day. I know that I'm biased. I love Archer Review. Go read our testimonials on the website. You will see tons of your students telling you, yeah, it's exactly like the NCLEX. We are very, very proud of that. So go listen to your fellow students and you will see 100%. What would be the high score in the readiness assessments? Well, I can't give you a number. It will be different from one readiness assessment to the other. It's about where you compare in that passing threshold. So again, don't look at the percentage, don't look at the number, just look at the high or very high. Now, going back to renewals, one thing that you guys had asked, hey, how do we renew? Now I'm seeing when we do renew, are they the same questions? Yes, we have one Q-Bank. They are all, when you buy, you get all of our questions. We're giving you everything, okay? So if you go and renew, we don't have more questions to give you. They're still that same group of questions. Okay. I'm looking to sign up for the mock NCLEX tutoring. What is the mock NCLEX? So this is when we take a small group of students, there's a maximum of 15 students, and we go through specific NCLEX questions rapid fire to test your readiness. So the mock NCLEX is designed to really give you a taste of the variety of questions you're going to see on the NCLEX and gauge how ready you are for those categories. And while you go through, it's not like you're just sitting there doing this test the whole time with somebody watching you. Every time you do a question, rapid fire, you get the answer and explanation from a trained NCLEX coach. So that coach can really help you with testing strategy. You can really see, like, this is probably why I got this question wrong. They can help you break down that question in real time. So if you're interested in our mock NCLEXs, if you're interested in small group tutoring on any subject, we have small group tutoring on pretty much anything that you could need. I'll make sure that you get the link here in a second. Let me go ahead and pull it up. archerreview.com. And then at the very top, all you have to do is click on nursing and choose the exam you are studying for. And then you will see private tutoring right there. So we have private tutoring for the NCLEX. We have private tutoring for throughout nursing school. So if you really need help with your anatomy and physiology exam, your med surg, you're really struggling with pharmacology, you can go see all the different tutors that specialize in those areas and are ready to help you during nursing school as well. As you guys have seen over the past years, Archer Review has grown from just being an NCLEX company to a group of nurses trying to help you all future nurses through every stage of your nursing journey, from getting into nursing school to when you go back to grad school and you want to be a nurse practitioner. We have got your back. We really want to support you all throughout. Okay, so once again, the email, if you need to reach out to us, nclextutors@archerreview.com. We can't reach out to you, but you can reach out to us. So if you popped your number or email anywhere and you need us, please just go ahead and shoot us an email, and we will make sure that we get back to you. Let's see, Jean, for the post-test, how much are we supposed to get? I really want to see you guys getting at least 4 to 5 out of 5 on that post-test. But with that being said, look at your score. Look at what you did pre-test, and then look at what you did post-test. Did you see an improvement? That's my real goal. That's what I really want to see. Is it possible to have a one-on-one assessment? Absolutely. Again, private tutoring for NCLEX, nursing school, mentorship, coaching, whatever you need, we have got a practicing nurse ready to be your cheerleader. So make sure I put the link in the chat over there. It's that nurses.archerreview.com/private tutors. Give that a click, or just go to archerreview.com, click on private tutors at the top, and we are going to get you situated. All right, can I access this video? This specific video will live on Facebook and YouTube for a little while. You've also got a much more comprehensive pediatric video that includes all of GI and more, part of your on-demand and sure pass combo. So for those of you who are already Archer subscribers and you've already got this, awesome, here you go. Go into your portal and it's there. If you don't have it yet and you want it, here's the QR codes to sign up, or just head over to archerreview.com. All right, good luck. I see some of you testing June 22nd. Some of you are testing just next week. It's coming up really soon. We are so excited for you. You guys are going to do excellent. Make sure to shoot us a message. Let us know once you've tested so we can give you a shout out. We are so proud of all the hard work you've put in. I know that all of this is really challenging. The pediatric GI stuff is not easy. There was a lot to go over, but we really strive to be a dedicated team to you. We are committed to your success as future nurses. So even though it's hard, it is worth it. Thank you for trusting us. Thank you for joining today. Again, if you have any further questions, just give us a shout at NCLEX tutors@archerreview.com, and we'll see you back here next time.